and we were discussing vaginal discharge syndrome, and we talked about that whitish, thick discharge, which is often attributed to yeast infections, and that can be treated using antifungal creams or pessaries or any antifungal medicine that you will be prescribed. And then we had also spoken about an offensive, fishy discharge that sometimes women have, which is attributed to bacterial vaginosis. And I was saying this is infective, but it is not a sexually transmitted infection. It can, to some extent, be called sexually related, but it's not being transmitted from your husband to or to his sexual partners. Then there's the other discharge that we would want to talk about, which would be the sexually transmitted ones. So these are the ones that we are most worried about. Um, so these ones are infections such as gonorrhea, infections caused by chlamydia, and infections caused by trichomonas. So what you find with these ones, they're a bit more dangerous to us women because, for example, with chlamydia, in 70% of the cases, you will not know. You are totally asymptomatic. You have no idea that you have contracted the infection. But then you will then find later on you start maybe experiencing subfertility. It's difficult to fall pregnant and you have no idea why. Or you might develop yatinoti Mutare, where you get an abscess. So this would be pelvic inflammatory disease in different stages of it. The worst case being the abscess that forms within your pelvic region and will need an operation to drain that abscess. So what am I trying to say? I'm trying to say let us not just look at whatever we are having and keep quiet and hope and just hope that it's going to go away on its own. Whatever you find that is abnormal, that is unusual to you, quickly seek medical attention and get treated while you still got a chance to save a lot of things, right? Okay, so I want to move on. Something else, vaginal discharge. If it starts becoming a bit blood-stained, then we are now worried about a possibility of malignancy. These are the cancers that may affect us. But before I go there, I want to talk about abnormal uterine bleeding. How many women here are between the ages 25 to 45? Okay, 25 to 45. All right, that's fine. How many have reached menopause already? Okay. All right. All right. Okay. So when we're talking about abnormal uterine bleeding, we're going to just split it by age group, right? We've got the little girls. When you find your daughter has any bleeding that's happening down there, seek medical attention, okay? Usually it's an issue of trauma. They were playing with toys, they were trying to put things down there that they shouldn't be doing. It could be an issue of sexual abuse. It could also be an issue of congenital malformations or some malignancy that is affecting the small child, okay? And then we've got the pre-pubertal girls or those that are about to start their menses or have just started their menses. Those ones tend to have irregular periods. I think we all remember that stage where you can have a period today and then go for 2 months, nothing, or in between you start bleeding heavily. And for those ones, it's usually corrected by giving them oral contraceptives. And I know for a lot of women, for a lot of mothers, that is taboo. We are not comfortable giving children contraception, but we're not doing it as a family planning tool. We're just doing it to control their hormones, okay? In most cases, it's a phase, it will pass. But where it becomes a problem and your daughter is bleeding every single month, she's being affected as far as the education is concerned, where you have to take her out of school whenever she goes on a period. That's disruptive, right? And you're better off giving her for just that period, and then once she's well controlled, you stop. Okay? Huh? And then we've got reproductive age women. So these are the women that we're expecting to be having a family. So here we've got several types and several problems that can happen with bleeding. You've got those that bleed too much during their periods, and usually we attribute this to fibroids or a condition called adenomyosis. Is there anyone who doesn't know what fibroids are? Fibroids. Okay. Okay. There's some that can't hear. All right. I'm sorry. All right. So I need to speak louder for them. All right. That's fine. Sorry about that. So fibroids are like growth. Atinongoti mapundu aya. They just start growing and overgrowing into to the muscles of the uterus. And if they are closer to the lining of the uterus, then you end up getting bleeding, heavy menstrual bleeding. Then adenomyosis is where you've got the lining of the uterus that has come inside the muscle layer instead of just being on the lining. So every single time you're going to bleed, remember we're talking about a layer where you're supposed to go on your menses on the inside here, but now you've got bleeding also happening this side. And this is going to be painful for you because it's abnormal. The bleeding is going to cause swelling, it's going to cause inflammation, things like that, right? And then we've also got people who get endometriosis. And this is where that lining, instead of just being on the uterus, it's now implanted on different parts of your organs. So you might have it, some deposits might be on your intestines. So every time you're menstruating, instead of menstruating from the lining of your uterus, you're also menstruating on top of the intestines. And this also affects fertility for reproductive aged women. So I'm just letting you be aware of these things. So when you find your daughter or yourself, you have very painful periods, come and see us. We need to investigate. And there are things that can be done to make these things better. But my main issue today is not about abnormal uterine bleeding, it's about cancers, right? Okay. So, is there anyone who's not married? All right. Your turn shall come to get screened. But for everyone else who has never been screened for cervical cancer, never been screened for cervical cancer. Okay. So you can forget everything else that I talk about today. What you need to remember is to get screened. Okay? Not just yourself, but your relatives as well. Your female relatives. Because you may have been screened, but I will see you coming to the hospital tomorrow with your mother or your tete or your mother-in-law or someone else who has never been screened. And for some of them, it's because they don't know about it. Then for others, it's mainly because they think it's not important. Cervical cancer is okay. Can you give us questions? All right. So cervical cancer is the biggest cancer in Zimbabwe that is affecting women. And there is no reason whatsoever for a woman in Zimbabwe to die of cervical cancer. Do we understand that? And there are different types of screening. We've got VIAC, which is visual inspection with acetic acid. I think most clinics offer that. I'm not sure if it's totally free, but I think most of them is free. And then we've got pap smears. If you go to Spielhaus or if you go to your gynecologist, these things can be done. We've also got a newer procedure that we do, which is HPV DNA testing. So for HPV DNA testing, we want you to get tested every 5 years. For pap smear, we want you to get tested every 3 years. For VIAC, if you are HIV positive, you get tested every year. If you are negative, you get tested every 3 years. Okay? So now, for those that are postmenopausal, if you're 65 years and above, and you have had at least 3 pap smears in the last 10 years, and they've all been normal, we can safely say you can stop getting screened for cervical cancer. And then if you have had 2 HPV DNA tests done in the past 10 years and they were normal, again, we can say stop. But the problem we have is of women who have reached menopause still getting VIACs. VIACs were created for poor countries, unfortunately like ours, where not everyone can afford to go and pay $20 to get a pap smear, or to go and pay, I think it's around $90 to get an HPV DNA test in private, but it's $5 at New Start centers for those that would want to do it. That's the most superior method of screening for cervical cancer. So if you then try and do a VIAC on a woman who's postmenopausal, chances are high your result is going to come back saying normal, and yet we've got cervical cancer right inside there. Okay. So in women of reproductive age, we've got what we call the transformation zone, and it's sitting quite close to the opening of the cervix. But as we grow older, that transformation zone moves on the inside. So what you are going to do is to do a test which just looks at just the opening and not inside. So you're going to get false negative results. And then you wonder how a woman can be told that she now has cervical cancer, but she had VIAC done 2 months ago and it was normal. Okay? So please encourage people to get screened. What are the risk factors for cervical cancer? For this, it's mainly the HPV-related ones. So people who get married really young, you start having sex before the age of 18, or start having babies before the age of 18. Your exposure to that virus, that called human papilloma virus, becomes longer than for other women. And then you have multiple partners, or your partner has multiple partners. That also increases your risk. Poverty on its own is a risk factor. And then we've also got other things like cigarette smoking that can also increase. Then we move on to endometrial cancer. If you have had a relative with breast cancer, ovarian cancer, or colorectal cancer, or even endometrial cancer, your risk of having endometrial cancer becomes high as well. So you would need to then see your doctor and to start talking about these issues. How will it present? So most people with endometrial cancer present with abnormal uterine bleeding, which we touched on earlier on. And then for diagnosis, it will have to be what we call a staging laparotomy. So we're going to take you to theater. Well, first we'll take a sample of your uterus to confirm, is there cancer or not? Once we've done that, we take you to theater. We are now removing your uterus. We are now removing bits and pieces of your lymph nodes in there. We are removing some fluid that we find there. We may remove your ovaries as well. And we want to see just how much that cancer has spread. So before we get there, again, I come back to get screened, get tested early, seek attention early as possible. Then we've also got ovarian cancers. And with ovarian cancers, again, there's that genetic component. Now, there are so many different types of ovarian cancer, so I won't try and go into those ones. How am I doing for time? 15. Okay. For question and answer? Okay. All right. Cool. So, for ovarian cancer, what most women are going to present with is an abdomen that just keeps growing bigger and bigger and bigger. And you see this woman and you might even think, is she pregnant? No. Sometimes it happens to young girls. Sometimes it happens to women in their early 20s, sometimes in their 30s. But mostly it happens to women above the age of 50. Okay? So they start complaining about early satiety. You go to eat food. Now she can only eat a little bit because she feels full. And then they might also complain about urinary symptoms, where every few minutes they need to go and empty their bladder. They come back, that bladder can no longer stretch to fullness. So once it's got just a small volume, you need to go and empty it again because it doesn't have enough space to stretch. They might also complain about constipation. They cannot fully empty their bowels, or they constantly need to empty their bowels. So these are things that we need to always be on the lookout for. All right, I think for now I'll entertain questions. So I've touched on vaginal discharge. I've touched on abnormal uterine bleeding. I've also talked about cancers. My main focus would be the cancers and getting people screened. All right, questions? Okay, so someone has asked about natural methods of controlling irregular bleeding. Um, it depends with how irregular the bleeding is. Hormonal is usually the best, but we can also give mshonga yamajaira, anabrufen, mefenamic acid. Those can work. For some people, they work really well. For others, they don't work so well. So for people with abnormal uterine bleeding, you would find that these non-steroidal anti-inflammatory drugs will work about 20 to 30% in reducing the blood loss. And then we've also got other drugs like tranexamic acid. So what that one does is it causes your blood to start clotting a lot faster than when you don't have it, when you're not using the drug. And this is going to reduce the overall blood loss in women. All right. Any other questions? Yes. Yes. Usually 3 months. So from 3 months to 6 months, in most cases, they'll be good. Yes. If she has bled so much that she is anemic and required a blood transfusion, we may end up actually making her take that for 3 months continuously without using the brown line at all. We don't want her to menstruate for those 3 months. Yes.
They got screened for through VIAC, and they had symptoms that were indicative of cancer, and they were advised to either take cryotherapy or consider removing the uterus. And then when they made that decision, they ended up not taking any of those measures because their spouse thought if they had their uterus removed, the sex was going to be different and things like that. And right now, she really looks like she's sick, but I'm thinking it's probably the cancer that's progressing. But she won't go back to the hospital. It's been 2 years now. How would you advise that? How would you deal with that situation?
Okay. So usually for a person who's advised, first of all, to get cryotherapy, it means they didn't have cancer when they went and they got VIAC. Cryotherapy is going to deal with, did you hear the question? All right. So the question is that there is a woman who went for VIAC and her VIAC was positive, and she was advised to get either cryotherapy or hysterectomy, which is removal of the uterus. The husband said no to removing the uterus because he was afraid of the side effects on sex. So it's been 2 years. This woman now looks sick. So when someone is told to get cryotherapy, they do not yet have cancer. But what we will have found are what we call little seeds of cancer that are there. The mic is for them. Sorry. Oh, I need to speak louder. Sorry. So for the patients that require cryotherapy, they are VIAC positive. They are not suspicious of cancer. So we've got 3 results that you can get for VIAC. You can get a negative result, which is good. You can get a positive result, or you can get a suspicious of cancer result. So once you have a positive result, we are saying they're little seeds. If this thing is left there, it could develop into cancer, but it is not yet cancer. So at that stage, we want you to get cryotherapy, which is where you're using ice to freeze off those eggs. And it works really well. You come back after 6 months, we check again, and there's nothing. Or you can get what we call LEAP, which is electrocautery. We are going to use electricity to burn those little seeds off. And again, that works really well. Or we can do an excision or a cone biopsy, just remove the tip of the cervix. And again, that works really well. So then when you have someone who was told 2 years ago to have an intervention done, and they come now and they look sick, chances are high this cancer has spread. It is, number 1, it is now cancer. Number 2, it is spreading. Number 3, she's going to die without treatment. So the stages of cervical cancer, we've got 4 stages. The very first stage, it is only on the cervix. Nowhere else, just the cervix. The second stage, it is on the cervix, but it has spread to to the upper 2/3 of the vagina. Okay? Third stage, it has spread to the lower 2/3 of to the lower third of the vagina. It has also spread to the pelvic walls. And these are the people that now have problems with the kidneys as well. It is causing obstruction so that the ureters are no longer working as they should. And then stage number 4, it has now started spreading to other distant organs. And we usually find it difficult to treat stage 4. I would advise you to advise her to come back to the hospital. If she looks sick, chances are high we're not going to do surgery on her. So she's going to keep her uterus, but she will now need radiotherapy. And unfortunately, in this country, at the moment, we do not have a radiotherapy machine that is working in government. So we've got 2 types of radiotherapy that can be done. There's external beam radiation, and then there's what we call brachytherapy. So with brachytherapy, this is what is still working right now. They put the instruments really close to where the cancer is, and it just works directly there. Whereas external beam, it's like your whole body goes in there and you're treated. So that external beam one is the one that's not working. What we have is the brachytherapy one. Please advise her to come back.
We have an online question which says, are there any preventative measures that can reduce the risks of endometrial cancers if your family member has been previously diagnosed?
Diagnosed. All right. So for endometrial cancer, if you have a family member that had endometrial cancer, you come to us. From a certain age, we can start monitoring you, doing ultrasound scans, and checking if there's anything developing. And we also check for symptoms and just that thickness of the endometrial lining. We keep checking it maybe every year, every 3 years, something like that. And if you are convinced that you are done with having babies, you have enough, you have 2 and they're enough, you have 7 and they're enough, you can come to us, and given that history, we will gladly remove the uterus. Okay? Yes.
That when you test, they test negative. So it means that you are not safe. You have to go for pap smear again.
It depends with your age. If you're
Especially like me, I'm 50 years. It's been a year from testing, what do you call it?
VIAC.
VIAC.
Okay.
And then I lasted, it's been years now not testing pap smear. I was doing that when I was in South Africa.
All right.
Because here, it's expensive.
In this case, for 50 years and above, I would advise you to go and get a pap smear. Yes. VIAC alone is not enough. You could go to New Start centers, like I said, for the HPV DNA. It's only $5. But in private, it's a lot.
I think as a follow-up question
Yes.
from, there's a question also which is asking, what's the normal age for a woman to remove her uterus?
With no reason at all for removing it, just I don't want my uterus anymore. There is no normal age for that. There's no normal age to just remove a uterus that has no problem at all, and you have no history of any gynecological cancers in your family. There is no age for that. If we agree to do it, we just want your money. Because imagine you come in and we're doing an operation on you. This is a big operation, remember? We put you under anesthesia. What if you don't wake up and we're just removing it for fun? Okay? So there's no age for that.
pane patambotaura nenyaya yevana pamamenstruation awo muchiti kana ropa ranyanyowanda we can also use family planning methods to reduce the flow of blood revana vasikana vedaro saka mubvunzo wangu uri pakuti toti azosvika age yekuroorwa hazvizoafecta here kuzozvara or anything else.
So my oral. Okay. The question is, let's say you have a daughter who has really heavy menses, right? And we as doctors advise that we give her contraceptives to regulate her hormones and to regulate her cycle. Will this not later on affect her when she gets married and she now wants to have babies? And my answer to that is no, it will not affect her. So oral contraceptives, I think a number of us here have fallen pregnant while using oral contraceptives just because you happen to forget once. Okay? So once you stop using them, return to fertility is quite quick. Yeah.
We have another question here, which says, what is the best treatment for fibroids? If one has fibroids, does it affect their fertility?
Okay. Treatment for fibroids. So we're going to start with conservative methods, which mean we're not going for surgery, right? So this is where I talked about the non-steroidal anti-inflammatory drugs, our brufen, mefenamic acid, indocid, things like that. They're not very effective, but they can reduce the amount of blood loss to some extent. And then we've got the oral contraceptives. They can also work. And then we've got tranexamic acid, which can also work about 50%. It will cause a reduction in blood loss. And then we've got what we call the Mirena coil. So this is an intrauterine device that has hormones around it. So in about 90% of cases, if you've been using it for a year, you'll find that blood loss is now very minimal. For some people, they even stop going on periods. And that is okay. This is what we were trying to achieve. And then we move on to the next stage, which is surgical. So we can have surgical removal of just the fibroids or surgical removal of the uterus as a whole, depending on the woman's fertility desires. Does she still want to have babies or does she not want to have babies? Which ties into the question of, does it affect fertility? In general, no, fibroids will not affect fertility, but once in a while, you've got fibroids that are located in strategic places where they are going to affect fertility. For example, if they're going to be close to the opening of the fallopian tubes, so they're causing a blockage there. That way the sperm can't go in or the fertilized egg can no longer come into the uterus to implant. Or you've got them scattered on the endometrial lining so that a fertilized egg trying to implant into the endometrium can't find a place to grasp. So every time it comes, it looks for a place, it goes out. Or you keep getting miscarriages. But it rarely happens, but it does happen. Fibroids tend to affect everyone to some small extent. Like almost all of us have a fibroid. If we were to do an ultrasound scan, most of us have a small fibroid. But then women who have never had a child are more likely to have those bigger fibroids that keep growing and they are many and things like that. And they are the ones that are now having problems conceiving. So usually it's because they didn't have a child that they get fibroids, not because they have fibroids that they can't have a child. Do you understand? No. So I was not yet done with the treatment. We've now got interventional radiology in Zimbabwe. So you can have uterine artery embolization. If you've got the money, you go, for example, Dr. Chatora's offices, MIC, and we put some substance into the uterine artery. This is our blood supply to the fibroids. So we cut it off. It's going to block the uterine artery, cuts off blood supply to the fibroid. It stops growing, it degenerates, it dies. Okay? And it's a day procedure. You just go in, you're done. In a few hours, you go home. It's expensive, yes. It's still expensive for now, but I'm not sure, but maybe around $600, $700. Maybe. And then we've also got focused, so magnetic resonance focused ultrasonography. You go in, they use the magnetic rays, and they start burning the fibroids. Again, it's a day procedure, 3 hours, you're home. Okay? But these are newer methods. Sorry? That's the problem now. Yes, she's asked, will you still be fertile? For now, it seems no. Chances are high you will lose your fertility doing that. Yes. Yes. All right. No, it's fine.
Thank you. So I wanted to ask on the issue of fibroids. You were talking about cancer. Is there a screening yekuti unokwanisa kuonekwa kuti une fibroids? Because inini I had fibroids. I only realized that I had fibroids. That one number. I think I was 4 weeks or 6 weeks. So they start growing baby
Achikura.
achikura. So is there any screening that can be done maybe like we're saying kuti for those vanenge vaita late marriage maybe unonoka kuita mwana. Is there any screening inokwanisa kuitwa?
Ultrasound scan. Okay, so the question is there any screening that can be done for fibroids? And the answer would be get an ultrasound scan. Wanonoka kuroorwa, get an ultrasound scan. If you have symptoms, usually fibroids asingakunetse. You're not bleeding heavily, asikukukanganisa with anything. Hapana zvatinoita twasiya. Ipapo kana akukunetsa itwabvisa. Anodzoka. Anodzoka. Because of fibroids, yes, that is okay. We will accept that. We have a reason for taking that fibroid out, that uterus out. Yes.
Just remind everyone that if you do have your uterus removed before you reach menopause, menopause comes earlier.
Yes, that is true. If you're going to have your uterus removed before menopause, your menopause is going to come earlier. Yes. But in most cases, we try to remove just the uterus and we leave the ovaries there. So they are still secreting hormones. So you're still okay. But if for some reason we remove the uterus plus your ovaries, you will need hormone replacement therapy. Otherwise, you start getting hot flashes at 38. Yes. Okay, I was saying, if we are removing the uterus, usually, if you are not yet at the age of menopause, we're going to leave your ovaries in situ. But if we take those ones out, you will need hormone replacement therapy. Okay? And I've realized also this is something that most women in Zimbabwe do not consider, but hormone replacement therapy is there to help you. Okay? After menopause, you start getting a dry vagina. During sex, it's a bit more painful. Sometimes you might get some bleeding or some trauma happening there, you can come and seek prescriptions. We'll write them for you and you get hormone replacement therapy. It doesn't cost that much. No, it doesn't. It doesn't. It's just like the oral contraceptives, something like that.
Okay, I have a question. I've been seeing a lot of cases of fibroids and gynecological issues generally now. They are more apparent, maybe because I'm now within the age group, but I'm finding the occurrences and the recurrences quite alarming. And I remember having a conversation with some colleagues to say, was there something that changed in the 90s that is affecting the early 30s, mid 30s ladies now that happened to our mothers, or they did something? They put something in the water. Because I've actually been seeing it's a lot. And I was also wondering if there's maybe an ongoing study that is investigating it, because it's actually quite significant.
Okay. So the question now is, why is it that we're getting a lot more gynecological issues coming up in our age group? And yet, long back, people were not getting so many fibroids or things like that. Is there a problem? Is there something that happened that our mothers took or something that is making us have all these issues? There is no study yet to look at that, but I would agree with you that the cases are more common. But I would say the problem, it's not really a problem. We're just now having so many ways to diagnose things. We now have ultrasound scans. We now have many gynecologists. So while our mothers may have been silent about certain things, we are now more open and we tend to go and seek treatment. So we're now diagnosing these things a bit more than in our mothers' generations. We don't have numbers of how many women died back then. But remember, women would die, he marries another one. And we know of our uncles and aunts who were raised by stepmothers, but no one talks about what had killed their mother initially. So I think that's what has happened.
We have talked about discharge. We have talked about fibroids. We have talked about cancer. So I'm saying, as women, married or not married, iyo sex yatinoita mudzimba umo haina chainobatsira here, either tikaitisa pamwe zvinoredusa maproblem aya, pamwe tikaita zvishoma imbonyatsotibudirai, so that tikaendaombawo kuti tichanoitisa kana tichanoita zvishoma to the benefit yekudzivirira zviri zvamuri kutaura izvi. So I want to understand as a woman, is it going to help having more sex or kuregedza zvedu tongogara?
The question is, of the three things that we have talked about today, vaginal discharge, fibroids, uterine bleeding, cancers, how are they related to having sex? Should we have more sex or should we have less sex? So my answer to that is, remember right at the beginning when we talked about the definition of health, and we said health is what? It's everything. It's a state of physical, of mental, of social well-being, right? So the best way I'm going to answer you is, are you healthier when you have more sex? Mentally, socially, physically? Sarah, continue. Have more. Okay. So I say, remember when we're talking about the definition, right? So we're saying that health is a state of physical, mental, social well-being, right? So is having sex going to make you healthier or not? Are you physically better off when you have more sex? Are you mentally better off when you have more sex? Are you socially better off when you have more sex? Remember, we're talking within the confines of marriage here, right? Yes. So if it's good for you and it's good for your partner, have more. Pane nzira dzakawanda dzekuita kuti musana usarwadze. Okay, so online. Okay.
Okay, these are questions that we got from here. The first one, I think these are related. It says, does removal of the uterus affect sex? If so, how? Okay, that's a question. And then the other one is, what is the latest age that someone should stop menstruation?
Okay.
Can I put the third one? Or we can put separately? Natural method of balancing hormones, question mark. What is the cause of not menstruating for 3 years before you get to menopause? And then for this particular lady, she did a transvaginal scan and was told everything is okay.
Okay. All right. So I'm going to talk about the age of menopause. In Zimbabwe, that's usually 49 to 52 years. Okay? But remember, this is an average taken of many different women. Vamwe vedu tiri vatetetete, vamwe vahombe, vamwe vatsvuku, vamwe vatema, handiti? So people differ. But generally, 50-51 is the age of menopause. Okay? If you get to 55 and you have not reached menopause, go and see a doctor. That becomes extreme. Then the other question was, does having your uterus removed affect sex? And my answer is going to be no. Okay. So I would need somewhere to draw or to... Okay. Let me try and use my hands. Let us assume this is the vagina, right? It's a tube. It is blind on one end and it is open on one end, right? Then you've got your uterus, and your uterus is sitting on top of the vagina at an angle, okay? So it's got just this small part is the cervix that protrudes into the vagina. When we remove the uterus, we take this off. The vagina remains, okay? So, so pretty much sex is still possible. Okay. It should not be affected. If we remove both the ovaries and the uterus, then you have a problem because we've removed your source of hormones. Yes. And we rely on those hormones to keep the vagina moist, to allow it to expand, things like that. Ndopatinozoda hormone replacement therapy. Okay? All right. The question was, what about if we remove the ovaries together with the uterus? And that's where I'm saying there will be a problem then, because it's going to cause vaginal dryness because you need those hormones. All right. And then the last question was, sorry? Natural methods. Natural methods?
Okay, what natural method of balance, are there natural methods of balancing hormones?
Broadly, I would say yes, no. A healthy diet is going to do a lot of good for you. Exercise, maintaining a good body mass index, that will help you to try and control your hormones. So some women would take multivitamins, things like that. But I do not advise my herbal medications ariko kunzo. Okay? They're good for balancing your diet, but not so much for treating ailments that you might have.
And then the other question, what is the cause of not menstruating for 3
For
years?
3 years.
Did a transvaginal scan and was told everything is okay.
All right. So, not menstruating for 3 years. Menstruation now is dependent. It has 3 levels that we're going to talk about. You've got the hypothalamus and the pituitary. These are glands that are located within your brain. Okay? So these are the ones that then secrete other hormones that come and work on our ovaries. Then we've got, so you can have a problem with the pituitary or the hypothalamus. Then you can have a problem with the ovaries themselves, failing to secrete the hormones that would cause menstruation. Then you could have a problem with the uterus itself, failing to menstruate. So it could be either that lining is simply not getting thick, or there's a blockage somewhere that's preventing all that blood from coming out. So if she had an ultrasound scan that said things were okay, the problem is not with the uterus. The problem could be with the ovaries, or the pituitary or the hypothalamus. So they need to get blood tests to check for their hormonal levels at that level there. All right, you had a question? Yes. Uh-huh. Okay. Mm. All right. I think we should. Yes. Okay. Uh-huh. Oh, there was a question. Okay. So we have a question here. Is there a healthy diet to prevent cervical cancer? And can urinary tract infections cause cervical cancer? I think my answer to that would be no in general for both. Okay. The question is there a healthy diet that's going to prevent cervical cancer? Number one. Number two, can urinary tract infections cause cervical cancer? So cervical cancer is caused by human papilloma virus in most cases. More than 95% of the cases, it's HPV. Okay? And HPV is acquired sexually. Any woman who has been sexually active most likely has acquired HPV at some point. Okay? But we tend to be so healthy that our body fights it and it goes away. Okay? Which is why it is important for those with young girls, please get them vaccinated against HPV. We are trying to eliminate cervical cancer in Zimbabwe, aren't we? So let's get them vaccinated between the ages of 10 to 14. Even we can also get vaccinated if we wish to. It's just not yet available for older age groups within government. Okay? Yes. All right.
Okay, another question, is there any treatment for polycystic ovarian syndrome? Another one, is there any permanent treatment for severe dysmenorrhea besides hormone therapy?
Okay. Let me do it those. So, polycystic ovarian syndrome. Okay. Polycystic ovarian syndrome, you've got little cysts, tumapundu so tunenge twine mvura that are growing on the ovaries. And unfortunately, these cause hormonal imbalance. And they may lead to a person developing acne, to having heavy menstrual bleeding, to having subfertility issues. It's, it's a very wide topic, and there are treatments available for that. Treatments can be hormonal, treatments can also simply be lose weight, have a healthy diet. Once you start secreting hormones in a better way, the polycystic ovary might also resolve. But for those ones, I would say seek help with a gynecologist. It's something that's difficult to generalize. And then for dysmenorrhea, painful menses, usually non-steroidal anti-inflammatory drugs are enough for some people, but there are different treatments depending on the severity of, of the condition. You will find that others, once they start having babies, it stops. And usually it's because once you've started having babies, you've also started oral contraception. Okay? Question? Yes. The hormonal imbalance, no. Well, okay. In general, no. But we're going to look at, for example, endometrial cancer. What causes it is because you keep getting estrogen being secreted um, in larger amounts and not having enough progesterone. So every time you go, you get pregnant, your body is going to be secreting progesterone for 9 months. So when you don't have that break, which is why we're saying women who have never had babies are at higher risk of having endometrial cancer because of that imbalance. Women who are bigger, who are obese with body mass index above 30 are at a higher risk because fat tissue secretes estrogen as well. Okay?
Last two questions. What is self-inflammatory disease? What is the treatment? And then this one, it's an online question. It says, is there any remedy for infertility caused by STIs?
So these two questions are actually related. What is PID, which is pelvic inflammatory disease? So this is an infection that starts from the lower genitalia, which is your vagina, your vulva, and it starts going inside. So it now then passes through your uterus, it goes to your fallopian tubes, it can go to your ovaries, and it can go to the spaces outside of the uterus, other spaces there, okay? So it is usually caused by sexually transmitted infections like your chlamydia, your gonorrhea. All right. And it can be treated by using antibiotics. And then is there treatment for subfertility that is caused by sexually transmitted infections? Yes, there is. There are different types of treatment for subfertility. It depends with where the level is. So 30% of subfertility issues are due to problems with the woman, 30% problems with the man. The remainder is a combination of the two. Okay? So in women, STIs usually cause blocked tubes. So you're secreting eggs on one side, but those eggs do not have a passage to then pass through and meet the sperm, or that fertilized egg does not have a chance to go and implant into the uterus. So in those cases, interventional radiology, they now open the tubes, or we can remove the tubes and do artificial reproductive techniques, where we take your egg, we take his sperm, we mix the two, and then we put them in your uterus. And you're good to go. Expensive though. I believe we have run out of time, ladies. It was a pleasure meeting you and having this discussion. Thank you so much.
Okay.
exercises